Hello, everyone. We've got a few people now joined. Hello, Dr. Heiner.
Good afternoon.
All right, we'll start the webinar now. So I just want to say good afternoon, everyone. Welcome to today's webinar, Understanding the Terminology for Respiratory Matters. We're excited to have you with us for this informative session that will help your understanding of the key terminology related to respiratory care. It's my pleasure to introduce Dr. Heiner. He's a renowned expert in respiratory medicine and intensive care. Dr. Heiner has a wealth of experience, having founded the ICU community committees and shaped the modern ICU practices in Brisbane. His expertise in respiratory and sleep medicine is backed by extensive training in Australia, Canada, and the US, and he holds licenses to practice in all 3 countries. Dr. Heiner is a founding member of the Asbestosis Research Group at the Wesley Research Institute and serves as an advocated advisor to the Department of Veteran Affairs. He brings a unique perspective to understanding of respiratory care, particularly as it relates to the ICU setting. In this session, we'll explore key respiratory terms and concepts, helping you better understand the language used in the field of respiratory and critical care. And Dr. Heiner will clarify important terminology and provide practical insights. I'd just like to remind everyone to make sure that they are on mute throughout the presentation, so that doesn't affect the quality of the recording. You'll be able to ask questions at the end of the webinar, and of course, you can put any questions in the comment section. The recording and the slides will be available and sent to you in the next day or so. So with that out of the way, I'd like to say welcome, Dr. Heiner, and thank you for joining us. And if you're ready, let's dive into the webinar.
Thank you very much. Good evening and good afternoon all. Thank you for the very lovely introduction. This talk, of course, is said to talk about definitions, but I thought that I would say more than that and just explain various things that we respiratory physicians use all the time and just take it for granted that people such as you understand what we mean. So I thought I'd start at the very beginning, and we'll start now. And what I'm going to do is talk to the slides. So on slide 1, respiration. Well, everyone knows what respiration is. It's the art of breathing. But to respire properly, people need to be able to move the air into the lungs so that gas exchange can occur and then is effectively distributed to all parts of the body. So you require a respiratory center which is intact in the brainstem, normal lungs, respiratory muscles in the diaphragm to pump the air into the lungs. And then, of course, you need blood that's suitable to transfer oxygen, and obviously a normal cardiac function. That slide is quite incorrect at the end there. Now, how does all of this happen? Well, lung anatomy consists of airways, lung parenchyma, and pleura. The airways are divided into the large airways and the small airways. The small airways being defined as all airways which are less than 2 millimeters in diameter. The large airways, of course, start at the trachea. They divide into 2, the left and right bronchi, and then undergo 26 divisions until the alveoli are reached. And once the alveoli are reached, they extend and equal to an area of 300 square meters. That's the area of a tennis court. So each and every one of us has a tennis court in our chest, which is involved in oxygen being transported into our blood and CO2 out of the blood. So when we breathe, each breath we take in about 150 cc's. Sorry, we take in 500 cc's, I'm sorry. About 150 cc's of that stays within the large airways, and that's regarded as the dead space. No gas exchange occurs in that area, which leaves about 350 cc's going to each lung. Now, a small amount goes into the esophagus and into the lungs, into the stomach as well. But with each breath, we take in 350 cc's, which is involved in gas exchange. We furthermore divide the lung disease into upper airway disease or lower airway disease. The upper airways include the sinuses, the nose, the pharynx, and the lower airways, which start below the vocal cords, all of those structures, the bronchi, small airways, etc. It's important to understand that the lining of the sinuses in the upper airways within the nose are very similar to or they're exactly the same as the lining of the lungs. So anything that happens in the sinuses affects what's going on in the lungs and vice versa. Now, we divide lung disease into two types, obstructive and interstitial. And to understand this, let me explain. When people take a breath in, and then we ask them to exhale all they can, irrespective of whether you're an obese, non-active person or an Olympic athlete, humans cannot ever empty their lungs. There's always gas left called the residual volume. The volume that is left in the lungs. What happens if we have an obstruction in the airway? We can't expel the air as well as we can. And if that happens, the residual volume increases. And if we relieve the obstruction, as we do in asthma, then the residual volume will return to normal. And but if people have a permanent obstruction, they'll have an increasing residual volume, which results in the condition called hyperinflation. The lungs become bigger than they should be. And next one, please. And that slide that's on right now just typifies what I've just said. Next one. Now, people who become hyperinflated, that is with an increased residual volume, that can occur commonly in asthmatics, people with chronic bronchitis, emphysema, and often more common in females than males. As women age into their 80s and 90s, their lungs expand slightly because the elastic recoil of the lungs decreases. This is important to us because almost every day, some very anxious elderly person will come along, having been told or having seen an X-ray report that states that they have COPD. And of course, these people say, how can this be when we have not ever smoked or been exposed to smoke? It occurs because of an anatomical change that occurs as the people get older. Now, just a little discussion about COPD. People who smoke, a certain percentage of them will go on to develop smokers-induced lung disease. Smokers-induced lung disease, if you look at that Venn diagram, is actually a mixture of asthma, emphysema, and chronic bronchitis. People who have been smokers may be predominantly emphysematous, or they may be predominantly chronic bronchitic. And in years gone by, these people were called pink puffers if they had basically emphysema, or blue bloaters if they had predominantly chronic bronchitis. Now, in the United States, they still stick to that definition. If people with smokers-induced lung disease, as it becomes more and more advanced, they do develop permanent obstruction, and then the label COPD is appropriate. Having said that, COPD now seems to be used for all people who have ever smoked and have hyperinflated lungs. And so it causes a lot of angst. But strictly speaking, not all people with smokers-induced lung disease, not all of them by definition, may have COPD. Next one, thank you. The next thing is interstitial lung disease. Now, interstitial lung disease is the part of the lung, essentially where the gas is, in those alveoli in the tennis court. And that's where oxygen is introduced into the blood and CO2 is expelled from the blood. It has various names. Interstitial disease, because it affects the interstitium or the gas exchange area in the lungs. Fibrotic disease, fibrotic lung disease, because that interstitial area can become scarred and fibrotic, or restrictive disease. And when it's restrictive disease, it's because the area around the lung, for example, the pleural cavity, becomes thicker than it should be. It may become thicker for various reasons, but in years past, it was very common when people had tuberculosis. And essentially, that thick rim of pleura around the lung stops the lung from expanding as it should. And that, hence the three different names. Obstructive disease means that the lungs get bigger because of the hyperinflation. Interstitial disease, it means the lungs get smaller because of the factors that I've just mentioned. Now, that's important for us because many people who come along to us with interstitial disease or have been smokers, and so they may have elements of both disease. So when that happens, it's important to be able to obtain copies of lung function studies, historical studies, and studies up until the present time when you see them. And in the classic case, you'll see that the patient's lung volumes are getting smaller and smaller as the person develops and deteriorates. Excellent, please. The interesting thing about interstitial disease is, there's a slide missing here, it may turn up, but the interesting thing about interstitial disease is that there's over 500 of them, and related to all sorts of diseases, exposures to various chemicals, and they all present in the same way. Initially with a dry cough, shortness of breath on exertion, and when they're examined clinically, they have crackling noises in the bases of their lungs. Now, up until fairly recently, 10 to 15 years ago, the way that restrictive or fibrotic lung disease was often diagnosed, and to have an appropriate diagnosis would mean they had to have a lung biopsy. But nowadays, with better radiological techniques, MRI scans, PET scans, etc., frequently people with interstitial disease, the pattern of the radiological changes will give us a fairly good idea of what's causing their interstitial disease. One of the large causes of interstitial disease are diseases which are interstitial diseases which are associated with diseases such as rheumatoid arthritis, lupus erythematosus. And if in fact patients present with those diseases and then start developing interstitial changes, it's London to a brick that you have decided you've developed the interstitial disease associated with their underlying disease progress. So what I thought we would do, I'd just talk to you about asbestosis. I think this is the most overdiagnosed, wrongly used term that people turn up with, and even radiologists, to take a shortcut, use the wrong terminology. Now, if people have been exposed to asbestos, it can affect the pleura, most commonly benign pleural plaques. And the benign pleural plaques on the slide are those black blobs at the base of the lung. And it may affect all parts of the lung, but the base of the lung is probably the most common area. They may develop diffuse pleural thickening, a rind of pleura around the lung. They may develop something called rounded or folded atelectasis, which is like a nodular lesion at the base of the lungs and frequently confused with cancer of the lungs. And lastly, mesothelioma. The first three diseases there, the benign, diffuse, and rounded atelectasis, never become malignant. And a lot of people have been told when they had this diagnosed that it's only a matter of time before they become malignant. That's not the case. Mesothelioma, on the other hand, is the thing that's the deadly disease that we don't like diagnosing in anyone. When asbestos affects the lung, it can cause asbestosis, which is a scarring fibrotic interstitial disease. It's not cancer or malignant. A lot of people come here with the thought that this asbestosis is similar to mesothelioma. And of course, there's an increased incidence of lung cancer in patients who have been exposed to asbestos, and also if they smoke as well, a much higher rate. Mesothelioma can affect the pleura, it can affect the testes, it can affect the pericardium, and more commonly now, it can affect the abdomen alone. It's quite commonly known that mesothelioma may invade the diaphragm and move from the chest into the abdomen, but that's quite different from abdominal mesothelioma. Abdominal mesothelioma, if diagnosed early, often can be cured by doing multiple operations to remove the nodules of cancer within the abdomen. And it's something I think we're all going to see a bit more commonly now, now that it's for some reason increasing throughout the world. Normally speaking, it has a much higher exposure to asbestos than those who develop pleural mesothelioma. Silicosis, very common and very topical recently. What happens with silicosis is these patients get multiple nodules, usually in the upper lobes, and elevated or increased size of the lymph nodes in the mediastinum, which is the area between both lungs. They may in fact have simple silicosis, and it doesn't increase in severity, but it may go on and become progressive silicosis, resulting in increasing pulmonary difficulties, and usually resulting in a decrease in life expectancy by about 10 years in various sufferers. And then, of course, it may also be associated with something called massive pulmonary fibrosis, where people get very heavy scarring in the upper lobes, and those people frequently die within a year or so. People who are sandblasters and use sandblasting for all of its reasons, they have to wear a ventilated suit, because if not, and they're exposed to sandblasting, many of those patients can go from having normal lungs to death in less than a year. Silicosis is often mistaken for a disease called sarcoidosis. There's some debate about whether or not they can occur together. Now, on the other diagram on the slide here, I thought I would mention to you, you see the two lungs, the purple looking areas, the trachea in the middle, and the heart below the trachea, and they are in the area called the mediastinum. The mediastinum also contains important nerves, the esophagus, and other blood vessels. Now, the pleura has two layers. It has a visceral layer, which is attached to the lung, and a pleural layer, which is attached to the chest wall. And normally, consider the pleural space being like an envelope. A small amount of fluid enters and leaves each day. But depending upon the disease state, ranging from injury through pneumonia to malignancies, pleural fluid may increase, cause symptoms, but it has numerous diseases that can cause it. Now, one thing that I know I was thinking of putting up a set of lung function studies here. Essentially, when you look at lung function studies, it has a top range of figures which relate to airflows through the various stages of the pipes or the bronchi. Then it has a second layer, which is related to the volumes in the lung, the amount of air in the lung when a person takes a big breath, the size of the residual volume, and the amount of moving in and out of your lungs. And then there's something called the diffusion test. Now, the diffusion test is a measure of how oxygen gets into the lungs, from the lungs into the blood, and CO2 from the blood back out into the lungs. And you often see two figures, one called the DLCO and the KCO. Now, if we have a person who has got very normal lungs, and let's assume that the lungs are the same size, normally with the right lung is a little bigger than the left lung, but let's assume that they're the same size. The DLCO and the KCO are both 100% of predicted. If we were to take out one of that person's lungs, the KCO would still be 100%, but the DLCO would be 50%. So the DLCO is the figure, the gas exchange figure we get after all of the other factors that can affect the KCO are taken into account, particularly the volume of the lungs. Now, cigarette smoking, if a person's anemic, if a person is breathing carbon monoxide or other chemicals, or if they have got heart failure, the DLCO may in fact be affected. So, as I've mentioned, this is a test that's very difficult for people to do, particularly if they're people who can't hold their breath, people who've got serious lung disease. So the ability to hold their breath, the hemoglobin level, any other gases, for example, we can tell if a person's been smoking when we look at the DLCO. All of those conditions may influence the DLCO. So when we look at the DLCO and we look at the result, we have to look for and make sure that the patient's been able to hold their breath properly, they're not anemic, and that the other factors that I've mentioned are all considered before we give a result. Now, the other area of ongoing confusion is bronchitis. There are two types of bronchitis. There's acute bronchitis, which can be caused by a bacteria or a virus, most often a virus, can occur in absolutely normal people who have never smoked and may occur complicating a viral infection such as cold, coryza, or it may occur without any upper respiratory infection and needs to be treated as such. People get acute bronchitis a lot though. People come in and they tell you that every time they get a cold, it goes to their chest. Those people, it's very suspicious that those people are asthmatic. So that the take-home message is that any one of us can get bronchitis at any time. But people who get bronchitis, acute bronchitis, after they've had a cold, or every time they get a cold, need to be considered as asthmatic, because essentially what's happening to those people is that the cold or the flu-like illness comes along, they feel better in 5 days, but in the meantime, it's activated the asthma. So what the patients who tell you that they've got asthma in their chest for the next 3 weeks are saying are correct. It's not the bronchitis or the cold in their chest, it's the activated asthma. Chronic bronchitis is a disease that we see in smokers or people who have been exposed to cigarette smoke or smoking from people burning dung as a fuel to cook, and also some other chemicals. What chronic bronchitis is it usually starts after a person has accumulated more than a 20-pack year history, and it's described as a person coughs every morning, particularly in winter, producing copious amounts of thick, tenacious sputum for at least 3 months in any particular year. And once it's occurred 2 years in a row, with that strict attention to definition, they're said to have chronic bronchitis. Chronic bronchitis is caused by a change in the anatomy of the airways. The glands in the airways that produce the mucus are hypertrophied, increased in size, and are turned into a mucus factory. So when the smokers come in and they've got that chronic cough, coughing up mucus every morning, worse in winter, more prone to get chest infections in winter, that's what chronic bronchitis is. It may not be associated with a bacteria or a virus at all. It's related to the changes in the anatomy of the airway provoked by cigarette smoke. Then there's a condition called bronchiectasis. Bronchiectasis is a condition that may result from neonatal diseases. It may result from infections during childhood and may occur in people as they age. A bronchiectatic airway is, think of a varicose vein. The airway starts looking like a varicose vein. The airway is dilated, tortuous, meaning it doesn't go from A to C by B, but it goes from A to B via Z, with distorted anatomy. These people, when that anatomy is reviewed under a microscope, they do not have what's called cilia, which are small finger-like projections in the airway, which are there to move mucus up and out. So what happens is the mucus becomes mucus lies in the airway, it becomes infected, and a vicious circle is projected with people then coughing each and every morning, coughing up copious amounts of sputum. I promise this is the last one. There's another condition called bronchiolectasis. Bronchiolectasis is a condition where a normal airway is full, stuffed full of phlegm, sputum. And this can be seen in asthmatics or in people, some people who have fungal disease complicating their asthma. The difference between bronchiolectasis and bronchiectasis is that bronchiectasis is a permanent change. Bronchiolectasis, if found early, it may be totally curable. And if the airway can be emptied and the asthma can be treated, the bronchiolectic airway can assume normal anatomical features once it's been treated properly. Now, I thought I would just mention this because this is very topical at present, and it's the direction in which asthma is going. You've heard, no doubt, about drugs like Symbicort, inhaled steroids that are used for asthma. There's a whole new group coming now called immunological agents. Now, these immunological agents are the agents which antagonize chemicals called interleukins. Some well-known ones are interleukin 4, interleukin 5, interleukin 13. These interleukins are produced by chemicals in the blood called eosinophils. And we often see eosinophils in increased numbers in asthmatics or in people who have allergic disease. These eosinophils producing the interleukins react on the airways, react on the sinuses to cause all the changes in the airways and in the sinuses, which cause the airways to narrow and the sinuses to become inflamed and the symptoms of asthma and sinusitis occurring. These immunological agents that we use block the effect of interleukins and have been very, very effective in treating chronic, severe, difficult to treat asthma. And I think over the next 20 years, we're going to see more and more of these interleukins being used to treat these people. I probably have 100 patients I'm treating right now, and the improvement in these patients is so satisfying for us who treat and for them who suffer. And in people in particular who have chronic sinus disease, nasal polyps, post-nasal drip, some of these drugs have always been miraculous in treating them. So that ends my formal talk today. I thought that would be enough for one afternoon. And I'd be happy to field any questions if there are any.
Yes, thank you, Dr. Heiner. That was really interesting and always exciting to see new treatments and the progress of medicine. If anyone's got any questions, please pop them in the comments if you're not confident to ask them. I have a question from someone who was unable to attend, just around the testing. How often or how recent do you need the testing on a patient? So if you were to give an opinion, how recent does the testing need to be and when would you require it to be redone?
We're talking about asthmatics?
Or any sort of case, I guess.
Well, with asthma, all of my postgraduate training occurred in the US and Canada. And I think what we learnt there is now the state that of the practice in Australia. And that is that every time you see an asthmatic, a flow volume loop measuring the FEV1 and the FVC. The FEV1 is how much a person blows out in 1 second, and FVC is how much a person blows out in 6 seconds. Now that's an objective test, and it's much better than the patient telling us how they feel, and much better than our ears, because both of those areas, the clinical experience of the patient and the doctor, cannot tell how severe the asthma is. Mm-hmm. People who die from asthma, they don't know that they're dying from asthma. What happens is their airways are slowly deteriorating over a period of time. They learn to live within that limitation. And then one day, the straw that breaks the camel's back occurs. They have no reserve and they die. Now, 20 years ago, 1,400 people were dying from asthma per year in Australia. Now it's about 350 people per year. Still 350 too many. But it's very important to get people to adhere to treatment, take their drugs, and see the doctors. There used to be one of the giants of asthma, Anne Wilcock was her name, and she died some years ago from breast cancer. But when she was teaching people like me and my generation and people before and after, she was saying that people should have, when they're unstable, they should be seen every 2 months until they're stable. Then they should be seen every 3 to 4 months. And anytime they had a cold or a flu, they should have a crisis plan, and their lung function should be done every visit, sometimes when it's only a week apart.
Wow. Yep. And so your lung function and walk test and your, you were saying radiology assessments, how often would you like to see those?
Well, the lung function, if we're looking at interstitial disease, asbestosis, silicosis, coal workers' lung, their lung function is more, it's more than just the flow. We look at their lung volumes and we look at the diffusion capacity as well. Now, that's also a very excellent test, objective test. And during the diagnosis periods, you might do them twice a year, but once the patient is being treated, you would do it once a year each time you saw the patient, and any time the patient may have an exacerbation. Chest x-rays and CT scans of the chest, if there's any progress with pneumonia, for example, it varies from disease to disease. When people have pneumonia, they need to have a minimum of 2 chest x-rays. They need to have one to diagnose the disease. And if the complication and their treatment is uncomplicated, they should have another one 6 to 8 weeks after they're better to be sure that the pneumonia has completely resolved. If the patient with pneumonia, it goes to hospital and has complications, then more x-rays need to be done during the hospitalization to see what the complication is. An interesting thing is now the Australian government accepted regular high-resolution CT scans be performed in former smokers to determine whether or not these former smokers had early lung cancer. Now, there have been many screening X-rays of various things proposed in the past, but none of them have changed the cost of lung cancer, meaning none of the early tests that they were done diagnosed enough cancer to make it effective in causing a decrease in total amount spent. But it's now known that if people have a high resolution CT scan and if in heavy smoke and if in smokers, it definitely has resulted in a decrease in cancers and an improvement in lifespan. And so that's been a very important test. I tell my patients who have been smokers to every year have a CT scan on their birthday.
Yep. Okay. Yeah, it's good. I just have a question myself, just sort of out of interest. You were talking about a higher increase in infection in the abdomen area recently. Any idea around the cause?
More mesothelioma in the abdomen, just not moving from the chest to the abdomen, but starting in the abdomen. And in Western countries such as the US, Canada, New Zealand, Britain, Australia, Japan, it's in that incidence of abdominal mesothelioma is increasing, and I don't think anyone really knows why.
Yeah. I just found that quite interesting. All right, well, I think that that's about time for us anyway. We don't seem to have any other questions, but if anyone does, feel free to reach out. I'm sure we can address those. But thank you for your time. It was very interesting. Thank you, everyone, for attending. Just a reminder that the recording and slides will be forwarded, and it will be on our YouTube, so at any time people can access us. So with that, I think we'll say have a good day, and we'll talk soon.
Thank you.
Thank you.
Bye-bye.